سلام دوستان ایرانی و ایرانی آمریکایی یوتا. Welcome everybody. My name is Shwan Jobden. I'm a biomedical engineering PhD student at the University of Utah, and I'll be moderating tonight. Thank you guys so much for coming. Welcome. It makes me so happy to see all these people. I mean, I'm already seeing over 20 people and more joining in every second, so this is great. I want to welcome you to our COVID-19 healthcare expert panel. And we are joined tonight by Dr. Rahimi, Dr. Taher, and Dr. Safai. And I will introduce each of them separately in a moment. I want to start by kind of telling you a little bit about the format that we have. So first, we're going to start with a little introduction from me. And then Dr. Safai has some slides that he is going to present to us on basic background of COVID-19. And then what we'll do after that is we'll open it up to questions and answers. And we ask that you hold your questions until after the presentation. The other thing I would like to request is that if you are not one of the panelists, that you keep your microphone muted unless you're asking a question. That way we don't get background sound from other people's microphone. So as many of you know, this coronavirus has really impacted all of our lives. I was looking at numbers just today, and we have 1,761,503 total cases in the United States and 103,700 deaths as of today. And that's a fatality rate somewhere between 5 and 6%. And as I'm sure many of you might be curious about the statistics here in Utah, Salt Lake City has had 4,800 cases and 70 deaths. And it is probably the hot spot in Utah. So with that, I want to introduce our panelists. We have Dr. Danish Rahimi, who did his undergraduate in mathematics and physics at the University of Utah and graduated from medical school at the University of Utah. He specializes in internal medicine and has a fellowship in geriatrics from UConn. He has experience in emergency medicine and internal medicine, and is presently working in senior healthcare at St. Mark's Hospital. Next, we have Dr. Mohammad Taher, who practices neurology in Utah County. He attended medical school at the Tehran University and graduated in 1987. He finished his neurology residency training at the University of Utah and did a clinical neurophysiology fellowship at the University of British Columbia in Canada. He's board certified in neurology, electrodiagnostic medicine, and vascular neurology. And finally, we have Dr. Masoud Safai, who graduated from the National University of Tehran and is board certified in internal medicine. He's currently the Senior Medical Director of Trauma II Hospitals, Intermountain Healthcare, McKay-Dee, Utah Valley, and Dixie. Please join me in welcoming all of our panelists tonight. Great, so with that, I'm going to pass things over to Dr. Safai, who's going to start off with presenting some basic information about COVID-19, and then we will just open the panel up to questions and answers from the audience.
Masoud Jan, الان شما اینو می‌بینین شام؟
Yes, perfect. And then if we could go into full screen view.
It's actually under edit.
Yes.
Oh, there we go. View.
بسیار. با سلام و تشکر از فرصت که فراهم شده. من یه مختصر خدمتتون عرض کنم که اطلاعات در مورد COVID-19 دیزیز بیماری کووید 19 هر لحظه عوض میشه و خیلی از اون مطالبی که ما الان خدمتتون میدیم ممکنه بعداً عوض بشه و یه فرمت دیگه ازش بیاد. ولی من میخوام یه مختصری در مورد این بیماری صحبت کنم و بعد میتونیم به سوالات پاسخ بدیم. یه چیزی که باید بدونیم اینه که تا قبل از 2002 ما 4 تا کرونا ویروس داشتیم توی به اصطلاح جامعه که اینا همون باعث سرماخوردگی میشدن و هزاران سالم وجود داشته و مسئله بزرگی برای انسان به وجود نمی آورد. بیشتر کرونا ویروس ها از حیوانات میان، به خصوص خفاش، و بعد به حیوانات دیگه منتقل میشن و از حیوانات دیگه به انسان. سال 2002 اولین بار ما پنجمین کرونا ویروس رو دیدیم که سارز نام داشت و در اون موقع این مسئله بسیار خبرساز شد و اولین کشوری که شروع شد چین بود و بعد از اونجا به یکی از کشورهایی که بسیار خیلی اون موقع در توجه قرار گرفت کانادا بود که یه سری از افرادی که از چین وارد کانادا شده بودن اونجا بسیار اونها مبتلا شدن. ولی چیزی که بود تا 2003 فقط حدود 8000 نفر مبتلا شدن و یه تعدادی بالاتر از 700 نفر فوت کردن و بعد از 2004 ما هیچ موردی از سارز دیگه نداشتیم تا 2012 که یک بیماری دیگه توی میدل ایست شروع شد از سعودی عربیه و از شتر به انسان منتقل شد و اونجا اینو اسمش مرس گذاشتن یا میدل ایسترن رسپیراتوری سیندروم و اونم به همین حالت محدود موند در یه سری از کشورها و تعداد کشته‌هاش بیشتر از 800 تا نبود. ولی چیزی که جالب بود در مورد این دو تا دیزیز، در مورد این دو تا بیماری این بود که هر دوتا با مرگ و میر بسیار بالای همراه بودن. سارز با حدود 10% بیمارا مردن و مرس با حدود نزدیک 35 تا 37% بیمارا مردن. و اینو من به این دلیل گفتم که چرا این دفعه اینقدر ما در مورد کووید 19 در ابتدا عکس‌العمل شدید رخ نداد. به خاطر اون به اصطلاح تاریخچه‌ای بود که این دو تا بیماری خیلی کوتاه مدت و در یک تعدادی بسیار محدود انسان بود و بعدم از بین رفت. تا دسامبر 2019 که اولین خبرها اومد بیرون که اتفاقاً BBC فارسی اون موقع اینو بیشتر دنبال میکرد تا CDC و بقیه جاها و اعلام کردن که بیماری جدید هست که اون هم از کرونا ویروسه و اسمش گذاشتن سارس کوو 2 اور کووید 19 و در ابتدا همه فکر کردن که خب اینم مثل بقیه کرونا ویروس ها مسئلهش حل میشه و از بین میره، ولی برخلاف انتظار ما دیدیم که این به سرعت پخش شد. اینو من گذاشتم اینجا به خاطر اینکه مقایسه کنیم که در ماه مارچ ما در کل دنیا 258419 نفر مبتلا داشتیم و حدود 11000 نفرم فوت کردن. فاست فوروارد تو می و میسیم نزدیک 5 میلیون. اینو هفته قبل من گذاشتم و امروز که چک کردم دیدم بالای 6 میلیون ما به اصطلاح افراد مبتلا داریم و بیشتر از 300,000 نفر هم فوت کردن و بیشتر این تعدادم الان توی آمریکا هستن و می‌بینین که چجوری به سرعت همه آمریکا رو تقریبا فرا گرفته و این نقاطی که می‌بینین به سرعت داره پخش میشه. حالا چرا این مهمه که سرعتش رو بیاریم پایین؟ به این اگه به این توجه کنیم می‌بینین که این نشون میده تعداد درصدی که ما به ICU بد نیاز داریم، تختایی که ICU باشه و ونتیلاتور داشته باشه. اگر 20% این بیماری در طول 6 ماه پخش بشه تقریبا تمام ایالت‌های آمریکا مشکل پیدا میکنه. حالا اگر هم 20% رو 18 ماهش بکنیم میبینیم یه سری ایالت‌های مثل یوتا هیچ مشکلی نخواهند داشت. و همچنین اگه حالا این 60% رو بکنیم برای 18 ماه همه دوباره مشکل پیدا میکنیم و اگه 60% در 6 ماه اتفاق بیفته تقریبا میشه بگیم خیلی دیزاستر بزرگی خواهد. برای همینه که خیلی اصرار دارن که این مسئله سرعت پخشش کم بشه. توی یوتا خوشبختانه یکی از بهترین ایالت‌ها بوده. من اینو توی چندین به حساب ریسرچ که بررسی شده بود، یکیش مهمترینش مال هاروارد بود. یوتا جزء از تاپ 10 ایالت‌هایی بود که به اصطلاح تعداد بیماریاشون کم بود و تعداد به اصطلاح فوتاشون بسیار پایین بود و تعداد میزان تستی که کردن، آزمایشایی که کردن بسیار بالا بود. ما حدود الان 9000 خورده کیس بوده که اینا شناسایی شدن. 670 تاشون از یه هفته قبل به اصطلاح بستری بودن و جدیداً حدود 113 نفر اینا فوت کردن مال تاریخ امروز. اینو من گذاشتم به خاطر اینکه در یوتایی که بعد بقیه ایالت‌های آمریکا یکی از بزرگترین مشکلات اون خانه‌های سالمندان و نرسینگ هوم‌ها هستن و 40 تا از اینا فوتی‌ها و امروز حدود 48 تاشون از تعداد کل فوت شده‌ها از نرسینگ هوم‌ها هستن و متاسفانه افرادی که تو نرسینگ هوم هستن مسائل بیماری‌های بسیار زیاد دارن و اینا خیلی در خطر هستن. یکی از مشکلات بزرگتر از اون اینه که می‌بینین که تعداد کسایی که اونجا کار میکنن و مبتلا شدن خیلی زیاده و این تقریبا به اندازه همون به اصطلاح تعداد کسایی که گرفتن این بیماری. لیست این نرسینگ هوم هم اینجا هستش که میتونین در چیز ببینین. حالا یک مشکلی که ما داشتیم این بود که این افراد من اینو موو کنم چون این مقدار دیده نمیشه این قسمت. بله، کیا هستن که بسیار از کجا گرفتن؟ یه سری مسئله بود که اینا که توی بیمارستان کار میکنن مشکلشون بیشتر از هم هست و میبینید که اون قرمز هلث کیر پرووایدر هستن که تعدادش بسیار پایین هستن. بیشترین تعدادی که ما میبینیم کسایی هستن که یک نفری که مبتلا بوده به اونا نزدیک بوده و اونا میدونستن اون فرد مبتلاست. در ابتدا ما تعداد زیاد داشتیم که در اصل مسافرت و کروز و اینجور، ولی این به سرعت کم شد و حالا تعداد کسایی که یا نمیدونن سورسشون کجاست، منبعش کجاست و یا از اونها هستن که با آدم مبتلا در تماس بودن بیشتر از همه هستن. از اونایی که میدونستن کی مبتلاست 60% از خانواده ها هستن. یعنی یک فرد تو خانواده مبتلا میشه و بقیه افراد اونجا مبتلا میشن و حدود 25% هم در محلهایی که مثل پارتی و مهمونی و اینجور چیزا، سوشال گدرینگ ها، اونجا به اصطلاح مبتلا شدن. جالبش اینه که کسایی که از محل کار مبتلا شدن کمتر از 5% تو یوتا و بیشترین قسمتی که مهمه قسمتی هست که افرادی که به اصطلاح در خانواده مبتلا هستن باید حتما آیسوله بشن. یه سوال بود در مورد که کدوم ایج گروپ مبتلا میشه. اتفاقا ما تو بیمارستانا دیدیم که ایج گروپ هایی که هستن اینطور نیست که افراد جوان مبتلا نمیشن. شما نگاه کنید بیشترین تعداد کیس ها از افراد بین 25 تا 44 سال بوده و بعدش 45 تا 64 سال، ولی کسایی که در بیمارستان بستری میشدن بیشترشون افراد مسن هستن. یه چیز جالب دیگه هم که در یوتا ما دیدیم و بقیه جاها هم احتمالاً همین حالت هست، کامیونیتی هسپانیک و لاتینو حدود 15% حساب جمعیت یوتا را تشکیل میده و کامیونیتی به اصطلاح افراد سفید پوست 78% یا 78%. ولی میبینیم که افراد مبتلا با اینکه هسپانیک کمتر از 15% هست، ولی 38% یا 39% افراد مبتلا از همین تعداد 15% بوده و این نشون میده که تعداد افراد هسپانیک در اینجا بیشترین خطر رو برای مبتلا شدن دارن. کیا مبتلا میشن؟ این کسایی هستن که تستشون مثبت شده بوده و تقریبا اونایی که یک بیماری داشتن در صدر این لیست قرار میگیرن، ولی بقیه افراد کسایی که سیگار میکشیدن و یا بیماری‌های ریوی داشتن، بیماری قلبی داشتن، مرض قند داشتن، اینها افرادی هستن که بیشتر چانس دارن. ولی ببینین حتی افرادی هم که هیچ بیماری نداشتن باز امکان داره که مبتلا بشن. حالا اونایی که بستری میشن تو بیمارستان، یکی از جالبش اینه که اونایی بودن که بیشتر موارد مرض قند و بیماری قلبی و افرادی که بیماری ریوی و قبلا سیگار میکشیدن، اینها بیشترین تعدادی بودن که در بیمارستان ها بستری شدن. این نموداری که شما میبینین اینجا نشون میده که روند بیماری در یوتا چجوری بوده. ما دیدیم که یه دوره بود که به سرعت رفت بالا، بعد حالت به اصطلاح یه مدت میرفت بالا، دوره حالت فلت پیدا میکرد، بعد یه مدت میرفت پایین. جالبش این بود که تا قبل از می 26 ما دیدیم این روند به سرعت نزولی شد، ولی این احتمالاً مموریال ویکند مشکل برامون ایجاد کرد، چون دوباره می‌بینیم که این رفته بالا به سرعت. این بالا رفتن و پایین رفتن این یه مقداری به اصطلاح باید در دراز مدت نگاه کرد، برای اینکه امکان داره که بعد از مثلا 2-3 هفته دوباره ببینیم که این نمودار داره شروع می‌کنه میره پایین. ولی اگر همچنان به بالا بره، اون موقع است که ما باید دوباره کانسرن باشیم که آیا دوباره میبندن تا حالا یا نه. در مورد تست این بیماری ما 2 تا تست الان در حال حاضر هست. یکیش که به حساب بهش میگم PCR یا مولکولار، همون هست که به حساب سواب میکنن و از طریق بینی این سامپل میگیرن. این برای افرادی که علائم بیماری دارن و یا کسایی که به اصطلاح میخوان برن برای سرجری. الان تمام بیمارستانا اینا رو 3 روز قبل تست میکنن تا مطمئن شن که بیماری ندارن و بعد برای الکتیو سرجری اینا رو میفرستن. کسای دیگه هم هستن که میشن که مثلا که مسافرت میخوان برن یا بیماری کارهای مهم دارن، اونا رو هم میتونن این تست انجام بدن. ولی این برای اینه که در حالت حاد بیماری انجام بشه یا برای تشخیص اینکه این بیماری رو نداره. آنتیبادی الان ما داریم و دانشگاه یوتا و ARUP و اینترمانتن جفتشون این کار رو انجام میدن، ولی چیزی که هست این برای حالت حاد منفعتی نداره. معمولا باید 7 تا 10 روز بعد از بیماری بکنید، در غیر این صورت میزان آنتیبادی ممکنه به اندازه کافی نباشه که تست مثبت بشه. چند تا فکت که ما الان در مورد این بیماری میدونیم. یکی این که هنوز واکسنی درست نشده، بسیار در موردش کار میکنن و بعداً دوستان توضیح میدن. هنوز درمانی ما برای این درمان تضمین شده‌ای وجود نداره و در مورد اینکه این چه کورسی پیدا میکنه و چه جریان قرار میگیره بعداً در مثلا فرض کنیم پاییز یا زمستون یا سال دیگه، هنوز قطعیتی وجود نداره. اینو من گذاشتم به خاطر اینکه یک مشکلی بود که چه علائمی ممکنه پیدا بشه و این بیماری به یک گیرنده در بدن در سلول‌ها هست به نام ACE2 که به حساب متصل میشه و متاسفانه این گیرنده بسیار فراوانه در بدن انسان. یعنی تمام این ارگان‌هایی که شما می‌بینین از ریه و قلب و چشم و کبد و کلیه و اینا همه این گیرنده رو دارن. برای همین هم هست که ما انواع مختلف بیماری یا تظاهرات این بیماری می‌بینیم. ما در بچه‌ها یه جور می‌بینیم، در بزرگسال‌ها یه جور دیگه می‌بینیم، در افراد مسن یه جور دیگه می‌بینیم، در افراد جوان یه جور دیگه میشه و این یه مقدار بسیار مشکل ایجاد کرده برای اینکه درمان قطعی این بیماری باید چجوری باشه. من اینو توضیح نمیخوام بدم، فقط اینو میخوام بگم که این در مورد بیماری درمان‌های الان در دانشگاه یوتا و اینترمانتن بیمارستان‌های اینترمانتن انجام میشه که اینا بیشترشون بر اساس ریسرچ و یک سری از به اصطلاح استادیا هست. هایدروکسیکلoroquine دارویی بود که برای مالاریا استفاده میشد و خیلی سر و صدا ایجاد کرد که این مثبت. تقریبا الان به همه به این نتیجه رسیدن که هیچ تأثیری که نداره هیچ، ولی امکان داره که به حساب مرگ و میر رو زیاد کنه. هنوز یه مشکلی وجود داره که هنوز قطعیت پیدا نکرده که آیا در افرادی که زود استفاده کنن بیماری رو محدود میکنه یا نه و هنوز یه سری حساب مطالعات و استادیا داره انجام میشه و هنوز قطعیت کامل پیدا نشده، ولی سازمان جهانی بهداشت اعلام کرد که دیگه استفاده نمیکنه و بعضی کشورها مثل فرانسه و بقیه هم اعلام کردن که اینا استفاده نکنید. یکی دیگه هم که من توضیح میدم، ما اینجا به اصطلاح از افراد بیمارم اصطلاح خون میگیرن، اون سرمش رو جدا میکنن و میزنن به مریض. یه سری مونوکلونال آنتیبادی هم داره که بعضی از بیمار به حساب کمپانی‌های بزرگ دارن درست میکنن. یه سری داروها هم ما استفاده میکنیم، نه اینکه تاثیر مستقیم روی خود به اصطلاح ویروس داره، ولی این میتونه به اصطلاح باعث این بشه که تظاهرات حادی ایجاد نکنه، به خصوص در جوان‌ها که به سرعت اینا میتونن به مرگ بیانجام. رمدزویر یه دارویی است که خیلی در موردش حرف زده شده و دلیل اینکه ما می‌بینیم که واکسینا و به اصطلاح درمان‌ها به این سرعت رفته نه به خاطر اینکه در مورد کووید 19 اینا شروع کردن. این داروها معمولاً برای بقیه ویروس‌ها استفاده شده و به خصوص در مورد سارز و مرس اینا استفاده کردن و یا ایبولا و یه سری از چیزهای مثبت. برای همینه که ما این حالت قبلی رو داریم، از اینا اطلاعات قبلی هست که میتونه کمک کنه. این دارو کاری که میکنه اینه که میاد میره اون زنجیره‌ای که به حساب ویروس احتیاج داره رو به جای یکی از اون بلاکاش میشینه و وقتی که تو اون زنجیره نشست دیگه اجازه نمیده هیچ چی دیگه بهش وصل بشه و همونجا قطعش میکنه. در نتیجه ویروس نمیتونه به اصطلاح تکثیر پیدا کنه. یه توضیح مختصرم من در مورد این به اصطلاح یلو یا وضعیت زرد عرض میکنم و تموم میکنم این پرزنتیشن رو. گاورنر و به اصطلاح بقیه بیمارستان ها و دولت به حساب یونیورسیتی آف یوتا همه هماهنگ کردن که ما اینجا باید چیکار بکنیم و نهایتا به این نتیجه رسیدن که ما وضعیت رو از قرمز به نارنجی و از نارنجی به زرد منتقل کنیم و این معناش اینه که خب الان در حال حاضر میگه شما بیشتر از 50 نفر نمیتونن دور هم جمع بشن، باید حداقل 6 فیت از هم که فاصله داشته باشن. اگه نمیتونین اینو رعایت کنین باید حتما ماسک داشته باشین. اون به اصطلاح جایی که مثل دبیرستان‌ها و اینا میخوان ورزش رو شروع کنن باید چک کنن سیمپتوم‌ها رو قبل از شروعش و احتمال خیلی قوی مدارس برای مثلا مدارس ابتدایی و دبیرستان‌ها در همین پاییز امسال باز میشه. ورزشگاه‌ها رو یه سرشو باز کردن و به هر حال چرچ و بقیه جاها رو میگن حتما باید 6 فیت رعایت بشه. برای بیزینس‌ها این مسئله این هست که باز بکنن ولی یه سری خواسته‌هایی هست که مثلا فرض کنید 6 فیت از هم دیگه جدا باشن و غیر ذالک. اینا رو برای این بیزینس‌ها گذاشتن. و نهایتا این هم لیست کسایی هست که به اصطلاح های ریسک هستن و بقیه چیزا که به اصطلاح شما می‌کنید. یک توصیه که من می‌کنم اینه که حتما به اصطلاح سایت government.com covid19.com.gov مراجعه کنید چون اطلاعات بسیار خوبی داره. و یه توصیه دیگه اینه که دولت یوتا این Department of Health این حساب اپلیکیشن رو درست کرد، Health Together اپ. بسیار جالبه برای اینکه خیلی ساده است. وقتی که دانلودش میکنین به شما میگه که یه سری سوال از شما میپرسه و بعد میگه که حالا برین تست بکنین یا نباید تست بکنین و بعدم میتونه به شما اطلاعات بده کسایی که ممکنه مریض باشن و نزدیک شما باشن یا تماس گرفتین شما باشون. اگه اونها اطلاعات شده باشن به شما به اصطلاح میفرستن به صورت مسیج و بسیار مفیده هم برای کمک کردن به اینکه جلوگیری کنیم از این مسئله، هم که خودتون رو محافظت کنید. خیلی متشکرم. Sean, I'm going to send it back to you.
Thank you so much. A wonderful presentation. Thank you so much for putting that together and sharing that with us. So I think that the next thing we're going to do is open this up to the audience for questions, just so that we don't have too much chaos. What I'm going to ask is if you can to use the raise hand tool on Zoom. So if you're on your computer, you can click on participants at the bottom. And then there's a raise hand button all the way in the bottom right-hand corner. But if you're unable to do that, that's totally fine. Just speak up and we'll call on you and we'll go from there. There's also a chat function in Zoom. If you would like to type a question in the chat, that is fine as well. So I'll type an example right here. Here is the chat. So does anybody have any questions? Masood, do you see anyone with their hand raised?
I don't. It might be because that functionality might be kind of difficult for everyone to find. but if it's okay, I would like to raise the first question, if that's
Absolutely, please.
هر کدوم از متخصصین اگه لطف کنن، یکی از به اصطلاح سوالایی که مطرحه در خانواده‌هایی که بچه دارن، بچه‌هایی که حالا بچه کوچیک صرفا نه، ولی بچه‌هایی که مدرسه رو هستن، بچه‌هایی که با دوستاشون یه زمانی وقت میگذروندن، با همدیگه دور همدیگه جمع میشدن، ما چه به اصطلاح ملاکی رو باید رعایت بکنیم؟ حالا این سوشال دیستنسینگ به جای خودش، ماسک به جای خودش، ولی اگه بچه‌ها قراره که دور هم جمع بشن، آیا ما مدت زمانی رو که دور هم جمع میشن باید محدود بکنیم؟ در طول اون مدت زمان چه ضوابطی باید به اصطلاح رعایت بشه؟ اگه دوستان لطف کنن در مورد این مسئله مقدار توضیح بدن ممنون میشم.
Great. Do we have any of our panelists who want to take that question? Danish, your microphone is muted.
Is it? Okay, I can give you a suggestion, but I think there is no answer to that question, unfortunately. It depends on the level of the risks. You still have to take extreme precautions. As far as the daycare goes or the school goes, they are probably going to open it up because it's directly related to people being able to work. So they are going to come up with some, separations and precautions as far as the cafeteria goes and the classes goes. But beyond that, I do not see any other way. I don't know. We can ask Dr. Safai or Dr. Tar and see what they think.
So, مسعود جان، دقیقاً هم مسئله که دکتر رحیمیان فرمودن من قبول دارم و یه چند تا مسئله هست که دو تا قسمت داره این سوال. یه قسمتش خب برای بچه‌ها مسئله چی هست، یک قسمتش برای افراد بالغ و ادالت چی مثلا. در مورد بچه‌ها الان تحقیقات داره زیادی میاد بیرون و یه سندرومی به اصطلاح داره میاد برای بچه‌ها بیرون که بچه‌های بین به اصطلاح 1 سال تا 15 سال اینا مبتلا میشن و بهش شبیه یه بیماری داریم ما بهش میگیم کواتساکی سیندروم، در شبیه اونی که عروق رو به اصطلاح مبتلا میکنه و باعث درگیری مسائل قلب و بقیه جاها میشه و ترومبوزهای شدید میده. این بسیار نادره و نباید یه مقدار زیادی باعث وحشت افراد بشه، ولی اتفاق داره میفته. پرایمری چیلدرن هاسپیتال حدود 6 تا 7 کیس از اینا داشت و بقیه بیمارستان‌ها الان در سطح آمریکا دارن سعی میکنن که اطلاعات بیشتری از این مسئله داشته باشن. یه مشکلی که وجود داشت اوایل این بیماری‌ها همش میگفتن کواتساکی و تست نمی‌کردن برای کووید 19 و الان دارن تست میکنن. خب این مسئله هست که باید اگر بچه‌ها مثلا مریض میشن مثلا منتظر علائم کلاسیک بیماری نباشیم، اونا بیشترشون با مثلا حاد تنفسی اینا وارد نمیشن. برای افراد مسن‌تر بچه‌ها میتونن به اصطلاح نقش ناقل رو بازی کنن و نقش ناقل بازی کردن مشکلیه که خیلی سخت میشه چون علائمشون اولا کلاسیک نیست و اینا میتونن یه اسهال داشته باشن یا چیز دیگه داشته باشن و کووید 19 رو داشته باشن و معمولا هم خیلی چون تعداد بسیار زیادشون علائمشون خفیفه و به خصوص ما داریم طرف پاییز و تابستون میریم، اینا با سرماخوردگی و قضیه هم خیلی سخت میشه که تشخیص داد که اینا چه هست. ولی در مورد سوالت که چیکار باید کنید در مورد چیز، بیشتر باید به علائم توجه کرد تا مدت زمان که با در تماس هستن و سعی کنن که دستاشون رو بشورن و این چیزایی که بسیار بسیار کمک میکنه در جلوگیری از انتقال.
Thank you. I also wanted to point out that if you have a question in English or you would prefer an answer from the panelists to be given in English, you can absolutely request that and we can do that. Just because a couple people have messaged me about that. Do we have any follow-up questions? Okay, I see Mariam's hand is raised. Mariam, can you hear me?
Yes, sorry, I am out. How are you?
I'm good, thank you. You had a question?
Yes. ببخشید، ممنون از پرزنتیشنتون آقای دکتر. من یه سوال داشتم. اگر در شرایط فعلی کسی بخواد سفر بین المللی بکنه، اگر مجبور، میدونم که نباید سفر بشه تا اونجایی که میشه، ولی در شرایطی که سفر اجباری هست و با چیزایی که حالا دارم میگن، ریکامندیشن هایی که میتونید کمک من کنید، ممنون میشم.
در مورد مسافرت کردن، به خصوص در مسافرت‌های بین‌المللی، یه مقداری مشکل هست به خاطر چند تا چیز. یکی این که حتما باید از هواپیما استفاده کنیم و الان چیزی که بیشترین توجه داره برای اینکه تمام این استادیا نشون میده، این یه بیماریه که به اصطلاح از طریق دراپلت‌های تنفسی به اصطلاح منتقل میشه و هواپیما و کروز و اینجور جاها یکی از جاهایی هستن که به سرعت اینو میتونه منتقل کنه. بنابراین یکی از مهمترین چیزا اینه که چجوری خودتون رو توی اون به اصطلاح هواپیما محافظت کنین. اگه میتونین یه جای بشینین که به اصطلاح فاصله داشته باشین از بقیه، اگه نمیتونین حتما یه ماسک استفاده کنین. ماسک ها متفاوت هستن و حتی وقتی سرجیکال ماسک اینا استفاده میکنیم ممکنه بازم از اون طریق منتقل بشه گاغات و بسیار کمتر میشه خطرش. توصیه قطعی وجود نداره که N95 استفاده کنین، ولی اگر دارین و میتونین تحمل کنین چند ساعت رو به هر حال کمک میکنه. یکی هم این که بزرگترین چیزش اینه که بعد از این مسافرتتون حتما دستاتون رو بشورین، قبلش حتما بشورین این مسائل، و بستگی داره به کجا میرین، کدوم نقطه میرین. این بیماری از طریق تماس مستقیم با بیمار دیگه منتقل میشه. هر چقدر بتونین تماستون رو کمتر کنین و فاصله ها رو زیادتر کنین، امکان گرفتن زیاده. ما تو بیمارستان تعدادی داشتیم، متناوب داشتیم از بیمارا و خب ما میریم میبینیمشون، تو اتاقشون هستیم، باشون حرف میزنیم و هیچ کدوم از دکترای ما بیمار نشدن، به این دلیل که میدونستن چجوری خودشون رو محافظت.
ببخشید آقای دکتر، در ادامه‌ای که فرمودید، فکر میکنید این فیس شیلد ها کمکی میکنه برای طول مسافرت و مسافرتی که من مد نظرم هست، چون اینترنشنال هست با چند تا استاپ و نهایت مسافرت ما میرسه به ایران در نهایت، و خب اونجا الان وضعیت اصلا خوب نیست، این یه چیز مشخصیه، ولی فکر میکنید فیس شیلد کمکی میکنه یا نه؟
دقیقاً میتونه کمک کنه. به خصوص گاگل‌های هستن که مثلا میتونید شما استفاده بکنین. گاگل‌ها ما الان تو بیمارستان هر وقت که میریم توی جای قسمتی که مریضا هستن حتما گاگل میزنیم، حتما ماسک میزنیم و این خیلی کمک میکنه و این بسیار هم اتفاقاً کار خوبیه که انجام بدین. و دست شستن و دستاتون رو به صورتتون نزنین بسیار مهمه، به خصوص اگه ایران میرین مچ و بوسه و اینجور چیزا رو باید بذارین کنار.
من فقط یه نکته
بله آقای دکتر بفرمایید.
من فقط یه نکته اضافه کنم. اگر فقط بخواید شیلد بزنین و ماسک نزنین ممکنه کافی نباشه برای کووید، برای اینکه الان نشون داده شده که این ویروس ایربورن هم هست، یعنی حتی میتونه فاصله‌های خیلی بالا بره. ولی اگر برای فاصله‌های کوتاه میخواین سوار هواپیما بشین، بهتره که از صندلی ویندو استفاده بکنین، نه آیل وسط. توی مطالعات قبلی رو آنفلانزا که ایربورنه نشون داده شده که صندلی ویندو خطر گرفتاریش کمتر از بقیه جاهای هواپیماست. نه فقط نکته کوچیک.
ممنون از راهنماییتون، متشکرم.
منم میخواستم یه چیزی بگم، اتفاقا این چون در مورد خود مادر منم صدق میکنه در مورد رفتن به ایران. من فکر نمی کنم، چون معمولا اونایی که میخوام برن الان سناشون بالاست، بستگی داره که چقدر جوونی. اگر جوونی اینا که ریسکت پایینه مسئله ای نیست، ولی بخوای بری ایران چون 2-3 تا هواپیما بعد عوض کنی، بعد باید نمیدونم توی ایرپورت ها باشی، بعد من صلاح نمیدونم تا زمانی که واکسین رو واقعا دواش در بیاد برای ایران رفتن. اون وقت دیگه بستگی داره که چقدر اون شخصی که میخواد بره ضروریه که بره و باید بره دیگه، و الا پروتکشنی وجود نداره. همینطوری که گفتین شما تو این ایربورنه شما داری میری توی هواپیمایی که فضای بسته داره، مگر اینکه اون هواپیما رو کاری بکنن. بعد تازه تو جهان سوم من خود هواپیماها رو هم پرابلم میدونم، چون که الان باید هواپیماها اون مینتیننسی که داشته باشن ندارن. الان میدونه تو پاکستان سقوط کرده، یعنی امکان زیاد داره این هواپیماهایی که باید برن بالاخره باید از طریق امارات یا ترکیه یا از یه جای جهان سوم برن. من رکامندش نمی کنم، ولی گفتم دیگه بستگی داره که اون شخصا چی کار میخوام بکنن. یعنی من الان خودم مامانم میخواد بره ایران، میگم نره تا زمانی که، البته خب متاسفانه نمیدونیم چقدر طول میکشه واکسینشو بزنن و به احتمال زیاد واکسینش هم یک پروسس ساده ای نیست، خیلی طول میکشه، برای اینکه باید یه واکسین خیلی سیفی باشه که بتونن با آدما بزنن، مریض نکنه تا اون واکسینه بلای سرشون نیاد. خلاصه دیگه جواب دیگه ای نیست والله، به خاطر اینکه اون پریکاشنا رو هم بکنی بالاخره چیز خطرناکه، برای حتی جوونا هم خطرناکه، ولی خب دیگه اگه جوانن، کسی جوونه میخواد بره میتونه بره دیگه، اون مسئله ای نیست.
ممنون از راهنماییتون، متشکرم.
That was a great question. I'm seeing Mahnaz Paivar, and then I'm seeing Sanaz Hossainzadeh. Let's start with Mahnaz. I think you might be muted. Mahnaz? We can come back to Mahnaz's question. Okay, Sanaz, let's see. Let's go to Sanaz's question.
سلام میکنم. ممنون از آقای دکتر صفایی به خاطر پرزنتیشن خوبشون. من سوالی که دارم در رابطه با ماسک‌ها هست، چون ما این روزا تقریبا 2 هفته از کارمون شروع شده. بعد میخواستم ببینم ماسک ما چند نوع ماسک تو آزمایشگاهمون داشتیم از قبل که روش هم N95 زده، ولی هیچ کدوم فیلتر نداره. یه ماسک خیلی ساده است ولی خب خوب کیپ میشه روی دماغ، و یه سری ماسکایی حالا دیگه هست که جدیدن اومده، اینا فرم پزشکی ندارن که دوختنی هستن و اینا خیلی راحت ترن که بیشتر اینا رو ما استفاده میکنیم حالا تو محله. بعد ولی خب خیلی کیپ نیستن دور بینی و ما چون جای بسته هستیم باید ساعت طولانی کار کنیم، یه کمی برای تنفس سخت میشه و من شنیدم خودش هم از لحاظ ویروسی و اینا مشکل داره. میخواستم ببینم باید چجوری ما رسیم تو محیط، حالا خیلی محیط شلوغی هم نیست، گهگاه یه تعداد خیلی کمی آدم دیده میشه ولی جای کاملا بسته هست. یه سوال دیگه هم در مورد حالا جای شیر هست مثل رستروما، ما که دیگه مجبوریم سر کار، اینا چجوری هست؟ امکان انتقالش هست از این جاهای عمومی یا نه؟
مرسی برای سوالتون. چند نفر پرسیدن میتونیم سوالا رو به انگلیسی هم بگیم و جوابا رو هم به انگلیسی بگیم. I wanted to repeat the question. So from my understanding, we want to know how good are homemade masks, maybe masks that are not necessarily N95 or that don't have the filter that's, typically used. How effective are those? And the follow-up question, I believe, was about restrooms at work. How do you take the proper precautions at work? Does that sound like a fair translation?
بله.
Yeah. I was going to direct this question to Dr. Taher.
ببینید ماسک‌های N95 فقط توی بیمارستان‌ها و مواردی که ما مطمئن هستیم که یه بیمار کووید وجود داره استفاده میشه. در بقیه موارد خیلی سخته که بخوایم این ماسک‌ها رو گیر بیاریم. اولا اینکه گرون هستن، کم هستن و بهتره که اینا رو اجازه بدیم که در اختیار به اصطلاح هلث ورکرها قرار بگیره که اونا واقعا نیاز دارن تو بیمارستان‌ها. این ماسکای معمولی که از مثلا 2 لایه پارچه کاتن یا فلانل و اینا درست میشه، اینا برای دراپلت هایی که یا قطراتی که از کسانی که سرفه میکنن یا عطسه میکنن یا صحبت بلند میکنن و در هوا پخش میشه، اینا کفایت میکنه. حالا در محیط های بسته بهتره که از همین حداقل از اینا استفاده بشه، چون در آزمایشگاه شما ببینید اگر مثلا آزمایشگاه شیمی، فیزیک، بیولوژی، اگر N95 خیس بشه دیگه شما کارش نمیتونید بکنید، بعد بریزینش دور، دوباره عوضش کنید. در صورتی که این ماسکایی که از پنبه و فلانل اینا هستش رو میتونیم بشورین و دوباره استفاده بکنیم. در محل‌های عمومی هم شستن دست مهمترین چیزی هستش که باید انجام بشه، به اضافه اینکه باز هم از این ماسک‌ها استفاده بکنیم، چون کووید متاسفانه در مدفوع هم دفع میشه، چون میره در سیستم گوارشی و بهتره که مواظب باشیم که پخش نشه.
Any of our other panelists have something to add?
یه توضیح بسیار کامل خوبی بود. من فقط در مورد اینکه شما خیالتون راحت بشه اینه که N95 فقط برای موقع استفاده میکنیم. ما تو بیمارستان، من الان وقتی میرم بیماری مثلا با کووید 19 میبینم حتی N95 نمیزنیم ما، مگر اینکه ما بخوام یه پروسیجر رو انجام بدیم. مثلا فرض کن میخوایم لوله بذاریم توی ریه‌اش توبش کنیم، اونجاست که چون این ایروسولایزد هست و میتونه اون قطعه اون به حساب چیزا بیاد تو حساب و اینوالو کنه شما رو، اونجا ما حتما باید از N95 استفاده کنیم. یا اگه بخوام مثلا فرض کن اندوسکوپی کنن مریضو، اونجا ما N95 استفاده میکنیم. برای همین بیشتر مواقع افرادی که استفاده میکنن الان تو بیمارستانا کسایی هستن که مثلا فرض کن گاسترونترولوژیست هستن یا مثلا فرض کن انستزیولوژیست هستن و میخوان این کار انجام بدن. مشکلی که N95 داره حتما باید فیتینگ تست بشه. N95 ها متفاوت هستن و در چهره‌های مختلف میتونه اصلا شما به اصطلاح N95 هم بزنیم و اثری هم نکنه. در مورد فیلتر داشتن N95 فیلتر نداره هیچ کدومشون. اون چیزی که شما دارین بهش ریفر میکنین پپر هست یا به اصطلاح اون قسمتی هست که فیلترینگ هست. هیچ تفاوتی با اگر که شما N95 که فیتینگ تست شده و گاگل بزنین، این معادل همون به اصطلاح چیزایی هست که با چیز هست. شما در آزمایشگاه اگر کاری نمی‌کنید که ایروسولایز باشه متریالش، اصلا به N95 احتیاجی نداریم. فقط به قول دکتر طاهر دست شستن و به اصطلاح هم ماسک‌های معمولی خیلی بیشتر کار می‌کنه، چون راحت می‌تونه عوضش کنید و مشکلی باش پیدا نکنید. برای همین خیالتون راحت باشه. لازم نیست که N95 بزنید، چون تنفس کردن توش برای ساعت‌های متوالی خیلی سخت.
Merci. Do you think you could give a brief summary about what we've said about masks in English? Just for it sounds like we have several people whose spouses are in the meeting that only speak English, and I want to make sure they're not missing out on some of this information. Dr. Taher or Dr. Safi, just brief summary of what you just said. Sorry.
Yeah, you just need N95 mask in a hospital setting, not really for outside when you go to grocery stores, when you are in a lab or any other places. As Dr. Safai mentioned, N95 mask doesn't have a filter. Actually, if it has a filter, then you cannot use it in a hospital setting because filter can bring the virus in and it's dangerous. So the N95 shouldn't have a filter. But the regular mask, homemade masks are enough as long as they have 2 layers of cloth like cotton. You can use your t-shirt and clean it and make a mask or flannels. These are the common type of cloth you can use for homemade masks. When you go to a bathroom outside of your house, you need to use your mask and wash your hand.
hand washing at least for 20 seconds. That's very important. You have to wash your hands for 20 seconds. Otherwise, the virus is not going to go away.
Thank you so much. I have a question here from Sholay. She's having some trouble with because she's on mobile, but she told me what her question is. She wants to know, can the virus be spread through food or packages or takeout or, for example, frozen food? And do I need to disinfect my food? Do I need to disinfect my packages? Dr. Rahimi, do you want to try and give this an answer?
Yes, as far as the packaging and the chance of you getting it from food is very low, because you have to look at this statistically. You want me to answer in English? It might be easier if we do English.
Yeah,
so
sure.
That way. So it depends on the chance of getting it statistically or by probability is very low that somebody has touched the plastic with COVID-19 and that plastic has been there for the right amount of time before that virus dies. So you would get it from that. So it's not a route of transmission of the disease. So the hand washing and the general precautions is good enough, like wearing the mask, so if you sneeze, you won't sneeze the particles into the food and stuff. So the chances are low. I mean, as far as do you need to, wash everything when you go home, I would say no, but the routine things, like if you go home, you bring grapes or oranges, you wash them anyway. So those are always the routine washing. Otherwise, the chances are very low, so you don't have to.
Great, thank you. Do any of the other panelists have anything to add? Shola has a follow-up. With regards to plastic, does she need to disinfect, plastic? I think one of the big concerns is a lot of people are ordering packages from Amazon and they want to know, do I need to spray things down?
As I said, I don't think so, because as I told you, the probability of getting that infection, because you have to have a package that comes from Amazon, which Amazon also does their own precautions for COVID-19. And then the chance of somebody having COVID and then handling the package without the precautions to transfer that virus to that package, and then that package takes a day or two, whatever it takes to get to you, the chance of it surviving is very, very low. So you just have to do the general precautions, wash your hands and handling the package, and then get rid of it, properly. Other than that, I do not think it's a high risk to do that, to be very anxious or worrying about it.
I want to add one more thing to that one. This is a moving target. And we had from a kind of frenzy of wash everything and just kind of cleaning everything to the point of that now CDC is kind of talking about food and everything is pretty safe. And even there are some more study coming out that this is a droplet disease. So I would recommend the same thing, that we should really, consider all sorts of precaution for just kind of, preventing this. Washing hand is the most important things. But I would not say that eating food or something like that puts you at the high risk for this disease. And I think that you probably have much more chance to get this one from a person that has the disease and been with you for 15, 20, 30 minutes, talking to you, speaking and all sorts of things, rather than getting from the food.
Great, thank you so much. Do we have any other questions? I don't see any hands raised currently.
I have one. It's very ironic that I have the right of a host However, I can't raise my hand. I can't figure that out. Sorry about that. So
No, that's totally fine. It's tricky.
it is
Well,
tricky.
there was another question I saw that appeared that says how long the virus survives. And I mean, as far as the droplet goes and the air goes, if somebody coughs or sneezes, right now the study says that it can last and stay in that closed environment for 7 to 8 hours, even as high as that much, if you're in a closed environment and you have somebody who's so. And then different surfaces, they have different answers, which I haven't memorized how long they last, like in a paper, plastic. They have certain amount of survival depending on what environment they also are in. So the question, I mean, is most important one is how long in the closed environment they survive. And that's how I've heard somewhere between 3 hours to 8 hours even that they can survive. So opening the windows, have circulation of air in the environment that you're in, or outside is a lot safer than indoor gatherings because of that reason.
Great. Masood, was there anything else?
Yeah, I had two questions. One was that I think Farzad already asked that in terms of the surface affinity to this virus. The second question is about newborns. How susceptible are newborns to this virus?
That is very interesting question, and a very good question actually, because we had this issue of that, would that transfer from placenta to the babies or not? And for that reason, we just kind of know we would test all pregnant women coming to the hospital with symptoms, and because it could put them, there are other people, healthcare workers at risk, and all pregnant women less than 37 weeks, we're going to check them too. And the chance of passing this one from, like, if you want to compare this one like to AIDS is a great chance of passing this one to the babies. With this disease, this is very, very low. There's still a lot of the study has to be done, but that is very low unless that the person like kind of after has the symptoms and after that delivery, has a close contact with the baby, kissing, breastfeeding, and all sorts of things. That probably increased the chance, but otherwise the transfer directly from mom to baby through the placenta is pretty low.
Thank you for your question. I have another question that I just got privately through the chat. Shaheen asks, do we need a mask for walking and jogging? Do any of our panelists want to cover this question?
Well, it depends on population around you. If it's a populated area and you cannot have that safe social distancing, you need to use masks. But if the space is wide and everybody is 2 or 3 meters away from you, yeah, you don't need masks. It's difficult to use masks while you're jogging. It's, just it's hard.
Yeah, they can be difficult to breathe in. That is for certain. Again,
the risk is low because, even if somebody passes by you, they're jogging, the chance of, I'm assuming it's outside and outdoors. So the risk is still very low. Unless, as Dr. Tahir said, you're in a place that there are hundreds of people, like demonstrations or something like that outside.
Great, thank you. I'm seeing Ghazal's hand raised.
Hi everyone. So I have a quick question. I have a question from our dear panelists who are practicing inpatient medicine. So I was wondering if a patient who was diagnosed with the disease and hospitalized, and then if they are getting cured and they are go for the discharge, I was wondering if a patient would still have any sickle, like any side effect from the disease, like like, are they more susceptible in the future for getting respiratory infections, or are they like susceptible of having epilepsy, any kind of neurologic symptoms in the future? Like, or they cure like as a normal person? I mean, if that's clear.
Yeah.
I'm going to leave the portion of the neurological problem to Mohammed to explain that.
Yeah, Dr. Taher is a neurologist.
Internal.
Yeah, the risk of, well, actually, it was a week ago, Lancet Neurology had a paper on this. There are two things can happen. One is the inflammation of the brain. It's rare with COVID, but it's been, we have been seeing more of it now. And it causes like the other inflammation of the brain from the viruses. So after recovery, some of these patients will have seizures. So this can happen with COVID too. The other issue with COVID is some patients, especially older patients who never had any symptoms of dementia after COVID, they developed dementia or like Alzheimer's disease. And in fact, people who have genes for Alzheimer's is called epsilon 4 genes. They are more prone to get neurological complications of COVID. But in other people, not the older, not prone to Alzheimer's, the other complications can happen like depression and anxiety. So these cases are treatable and probably they won't last long.
So regarding the second part of your question about the inpatient that they're being discharged home, we have seen several different scenarios. One is that full recovery and they had not had any much of problems. And I would say that those kind of patients might not have any different outcome than others. The other problem is that we are still learning about this disease. Like, for example, we see some patients have been reported that after being discharged, they came back with heart attack and death. And then we find out, oh yeah, there is some involvement of the heart, or some of them that had problem with deep vein thrombosis and pulmonary embolism or other type of endovascular disease. And that we find out, oh yeah, there is a ACE2 receptors on those endothelials and they cause this problem. So it is very hard to say they would not have problem, but majority of them, almost 80–90% of them that would be discharged home, they would not have much of symptoms or problems after that until we find out more stuff about it. So it's still, we are very early stage of that to see what's going on, because we have only a few months in this course of disease and we don't know what's going to be long-term problems for this disease.
Can I follow-up question? Oh, sorry, go ahead, Dr. Rahimi.
I was going to make a comment is that this virus affects a lot of organs. So the answer is how much damage is going to be left. It depends on, for example, if you get this disease and you already have some heart problems or neurological problems, it may cause secondary. So there are certain things that directly is affected by virus. And especially as we get older, the reason that a lot of older people die or they have comorbidities that die is not one thing, it's the stress that the virus puts on the different organs. And the result of that, if you get permanent damage from this stress, then yes, you could have seizures because you've had some brain damage secondary to the virus because it's put that stress and caused ischemia to the brain, or if it's caused heart attack or whatever. So as we get older or we have other medical conditions, in a way, it's not one thing, it's a combination of factors. So it's, and as Dr. Safai said, we don't have enough study about it to know what the effects are in 2 years or 3 years or 4 years from now on the patients that have had it.
You had a follow-up question?
Yeah, so specifically for the respiratory system, so because like the pathogen is like more as affecting on the respiratory tissue, I was wondering if like the if the capability of the respiration will get back to the normal. I mean if the lung would operate like as the usual, as the normal, as it was before.
Let me make a comment on that one. It's 5 to 20% of common colds are coronavirus, and they are usually upper respiratory infection. The difference between this one is lower respiratory infection. It causes pneumonia. And the answer how much damage they do, they probably does damage, because pneumonias can cause damages like scarring and decrease in pulmonary function. But again, we don't have long-term studies to know, because obviously it causes the older people and the one at high risk to die. And then there are certain people that survive. A lot of people survive. So even if as far as how much damage it's going to do, if you get full pneumonia and you're hospitalized, it's a high possibility that does affect the lungs. But I don't think the studies know enough about it yet.
I see.
One important thing is that we have to know that the course of disease is different from one patient to another patient. And so related to your question about the pulmonary problem after the recovery, like for example, if the patient had cytokine storm, the outcome might be different from a person that had only effect of the virus itself. So that's make it very difficult to say, okay, which patient is going to have more long-term problem and which one doesn't, and how bad. Because if one person really go through a very bad cytokine storm, being on the ventilator for 3-4 weeks, even some of them went on ECMO, they are going to definitely have some problem after the recovery.
Do you think you could explain to us a cytokine storm in kind of layman's terms?
Yeah, I'm sorry to use those terms that, you know, you're absolutely right. You know, sometimes when the people just kind of get a disease, rather than the disease itself causes much of the problem, your immune system attack those places. And rather than using, for example, if you were compared to the war, rather than using a gun, they're using the tank for a fight. And that's kind of really causes a lot of damage to the normal tissues. So that is the part of that immune system response. And we had many of the young people actually who got this situation. So for that reason, they are giving actually medication to suppress immune system and bring down this response from your own immune systems. That's what you call a cytokine storm.
Fantastic. That's perfect explanation. I see the next person with their hand raised is Albors.
Yeah, thanks so much, everybody. Thanks for this panel, and thank you to the panelists. I'm just wondering, do we know anything about when the vaccine will be developed, or is that like an impossible question to really answer or think about?
Thank you. That's an excellent question. Wait, Danish, you're muted right now. So do any of our panelists feel comfortable with that?
Well, I can start this, and then Dr. Safai can complete the question. Well, you know, there are two publications on phase 1 and phase 2 of the vaccines. One of them is from Moderna company. They're working on a type of vaccine. It's called mRNA. And mRNA is very similar to the shape of the RNA of COVID infection. And the phase 1 and phase 2 were successful, and now they're moving to this third phase. The other vaccine that recently reported in Lancet, China is working on it. That's a different type of vaccine, they're using a vector and putting the DNA inside the vector to create a vaccine. And that was successful too, the second phase. So, but there are at least 100 different types of vaccine are under development. So the problem with RNA vaccine is RNA is unstable, and the structure of this virus, unfortunately, is RNA. RNA is unstable, and you need fridge in order to move these vaccines. So it cannot be available everywhere. So this is the reason some companies are using DNA to insert inside a smaller virus to create vaccine, like Johnson & Johnson is one of the companies that works on that type of virus, the vaccine. So these are the information I have. So if the other panels want to add.
That is
more.
excellent.
Can I make a comment? The normal vaccine takes about 5 years or longer to develop normally. If we expedite it, it's going to take 1 year to 2. And this is a specifically, so now we are expediting this matter. And then if you look at it for the flu, we have guess estimate of what's going to be the next year's flu. Bill Gates is working on a universal vaccine, universal flu vaccine, but they haven't been able to do it. And so if we are going to be very, very optimistic and say it's going to take 1 year because vaccines needs to be safe, especially you're not going to give it to millions of people. And this is an RNA virus, as Dr. Tahir said, so that even makes it more difficult. So if we be totally optimistic that any of these techniques are going to work, you're talking about 12 months to 2 years, and it may take longer.
I have a follow-up question that came from the chat. Someone in the audience asked if you could elaborate on what do the different phases of the trials mean? So what is the difference between a phase 1, phase 2, phase 3?
I want to add a little bit on the previous question and then follow up that one.
Sure.
The one big issue is that we have to know, just kind of consider that one, is these vaccines that they are working on it right now are not completely start from scratch. It's because of that we had SARS and MERS. Millions of dollars actually put on those kind of those vaccines since 2002. And most of those studies and the works that we are doing right now is based on those work have done before. So that's one advantage we have. It's not totally new for them. The second is kind of, as Dr. Tahir and Dr. Amy so mentioned, is that when they are talking about vaccine, is so many different elements to that one. Like, for example, you can use the vaccine on the young people and very effective because of their immune system working good. And then you are using on age 55 and above, and then they are not working good. So it's kind of because of the immune system not responding. So then how much of the vaccine they have to give, how many doses and stuff like that. So that makes it much more difficult. But phases is that kind of right now that we are talking about is, the phase 1 is that they are developing the vaccine that has some sort of possible impact. And then they're using on either animals or something, and that's a preliminary stage. But then they're using on the very limited number of the people, up to 10, 12, 13, 14 patients. Moderna is one of the companies that started that to using this one for that phase. And through those patients, through those candidates, all of them response was great, and actually they are working on the portion of the virus that is on the surface of the virus that attached to the cells. So they call it S protein. So if they can destroy that one, then they cannot attach to the cells and they cannot pass through the body. So they did that, and immune system antibody response was great. But then few of those patients actually, because of they give them high dose, they had fever, and one of them even passed out. So then it's kind of risk. What's the risk of that to using in millions of people, as Dr. Rahimi said? So then phase 2 is that when, yeah, that's okay, safety is okay, they go to the larger number of the patient, and that both Moderna and Jenner from Oxford are using that one actually. That phase 2 just kind of know on 1,500 or more. Many of them could be old people, and then they follow up on that one to see if that's going to be okay or not. Then we have the phase 3 that is kind of much larger. They know the dose at that time, they know the side effect, they know the immunity, and just after that, they're going to have for millions of the people that most of the time, the process is that it starts with the high risk people, like healthcare people or some people that are involved with their care. And then they see that if there's no problem, go to the whole communal world and just kind of using it for everyone. So that's the phases that we have. And each phase is what takes months to do because it's not easy to get the information and results and everything else and coordinate those stuff.
I make a comment on the Oxford study that they did, which they give actually a vaccine to 1,000 patients, I mean, 2,000 people already, and then they said they couldn't come up with any result because the rate of the people that were getting the coronavirus in England started going down so fast that they could not make any conclusion. So it's not that easy. And then, so it is very complicated as of right now. And so who knows how long it takes, but those are all time. I'm hoping that the entire, planet, the entire countries, all the countries are spending a lot of money on it, and they can come up with some solution or some vaccine for that.
Great. I had a follow-up question from Shaheen. Do you guys know anything about Sorrento Therapeutics? They claim to be making progress on a medication. Do you have anything to say about that?
Do you know which medication exists specifically?
I can look. I honestly had not heard about this one myself. And I've been following the primary literature on this pretty closely. So I actually don't know. I don't know if I want to search for it while we're in the middle of this.
Right.
I can say, just briefly for just the 5 vaccine candidates that I've heard of. As you mentioned, there's the one with the Lancet paper Dr. Taher talked about. That's actually coming out of a Chinese company called CanSino, and it's an adenovirus-based vaccine. And then there's the Oxford one that Dr. Rahmi just talked about. They actually recently got $1 billion from the government to work on their next stage of the trial, which is going to have over 10,000 adults and children. Moderna, that's also out of the United States. That's, I think, a really promising candidate. There's another one out of China from the company Sinovac, which is it's just kind of like your classical inactivated virus type of vaccine. And then the last one that I think has a lot of promise is out of another company here in the US called Inovio, and it's a DNA vaccine. But those are like the 5 that I think have pushed the furthest in terms of clinical trials.
Shuan, can I ask you a question? I know there is a group of people that are doing, I don't know which group are they in this, they're using medical students and volunteers that they give the vaccine to, and then they infect them with the virus to see how much results they get. Do you know which company or which organization is doing that one?
I
should be
do not.
Chinese.
That would be, to me, it would help a lot to expedite the process, because you don't give it to they're just giving it to the young people. And I heard a lot of medical students are doing that, to volunteer for that, because they're at low risk. and then they would infect them with the coronavirus and see.
Wow, I have not heard of that, to be perfectly honest. I think that sounds very risky. I can tell you
Any
that
other stuff, Dr. Tahir, you've seen anything on that one?
No, but it should be a Chinese company. So I don't know.
Yeah, that would not happen, I think, in the United States.
To be honest with you, I was very optimistic about Oxford because I thought Oxford was because they've started earlier and they were in phase 2 and now they're in phase 3 from what you're telling me. Although they said the chance of working is only 50% recently, they said that might be. But China, we don't know. Again, China, I think they've had a head start, so they might be working. And you see, the other thing is the medication. When you're talking about the medication for this disease, we talked about the vaccine. The medications takes a lot longer for the studies to be approved. A vaccine is easier than the medication. And these medications that we have been trying are the drugs that China and other countries have had done. They're not the new drugs. They're the old drugs that tried for Ebola virus and didn't work. And then they tried it for this disease, as Dr. Safai was saying. So as far as medication goes for this disease, that's even harder to be approved. And so we are right now only looking at the old drugs we have because new drugs take so long that the best or the first attempt would be on the drugs that we already have rather than going and trying to make a new drug. And that's even harder than the vaccine. And I think in order for us to be able to overcome this disease, we not only need the vaccine, we need the treatment too.
Sean, maybe comment on the Sorrento company.
Yes, I saw that. So thank you so much, Dr. Kandahari, for sending us that link.
So that was just a study that was released on Friday, and it's an antibody screening, basically. So they have looked at a whole bunch of antibodies, and they have selected a specific antibody that's effective. But the problem is it's only preclinical studies. That means it's only on animals so far. It's got a long way to go to reach the clinical trials, as it was mentioned before.
Great, that's great information. I did not know that. Thank you for sharing that. I will say one quick thing. The reason I think Dr. Tahir said that study must have been in China is I don't think that's the way that most of these studies for vaccines have been conducted. They don't typically, at least in early clinical phases, give someone the disease. The way that they know if these vaccines are effective is they are looking at the antibody levels that the patients develop against COVID-19 after they administer these vaccines.
Yeah, I want to add one more thing. It's not all antibodies. It should be neutralizing antibodies. One issue happened with Zika vaccine. Zika was a bad disease in South America. When they developed the vaccine, instead of creating neutralizing antibody in the blood, it created another type of antibody. Actually, it facilitated the entrance of virus and made the disease worse. So when they make a vaccine, they have to be careful not to make the original disease worse.
Absolutely. So I'm taking a look at the time. We have about 12 more minutes. I want to make sure that anybody who has a question who hasn't had the chance to ask has the opportunity. Does anybody have any more questions?
I do, if no one else has any questions. And this question is for Dr. Rahimi. One of the things actually that you mentioned was that the younger generation is less susceptible to this disease. We've heard about that, but I'm wondering whether there are any metrics, any numbers out there that any studies that tell us, in terms of what the susceptibility, because we do hear that it affects the younger generation as well, and there are those who have extracted this virus and it's been fatal to them.
Well, if I said susceptibility, I'm probably wrong. The younger people would get it as much. Probably we don't know all the statistics on it. All we know is that out of 100 people that get it, 80 of them just have a cold symptoms or they have mild symptoms. 20 of them goes and ends up to be sick with, you know, high fevers and coughing or a lot of symptoms. And then out of that, you know, 5 or 6 ends up to be in the hospital, and out of that 5 or 6, 1 or 2 dies. So when I was saying the younger people, right now, as a country, we don't have any strategy to get rid of this disease, which like, you know, like Taiwan or like South Korea, they had. So what I'm saying like about traveling is that a young person could easily travel, because even if they get the disease, the chance of dying is lower, a lot lower. So as far as if I want to travel, I think the traveling should be done by the young people, not, you know, older generation, especially the ones that are high risk, because the risk of getting it is higher than, you know, other activity. And then if they get it, the mortality and morbidity is higher for them. So that's what I mean. As far as the susceptibility goes, I don't know if they know exactly whether if you expose kids and younger people, they don't get it as much. I don't know if anybody else in the panel knows the answer to that question.
Yeah, probably they get the same frequency. The only difference is younger people do not have as much as ACE2 receptors as older people. So when you have more ACE2 receptors, then you get more serious disease.
But we don't know the answer to the exactly, like if you expose, let's say, a group between 15 to 30, 45 or something, do the same number of people actually, I guess they all would get it. I don't know. I don't know the answer of susceptibility of it. But as I said, depending on how sick they get is the thing we know what the answers are.
But mortality rate is much lower for the younger generation than the older. But the possibility is still there.
Yes.
And maybe if I can comment, do you mind, Sean?
No, I don't mind at all, please.
Go ahead.
The other thing is the immune cells. Basically, as you get older, your immune cells become less functional. So there's this magic age of 30 that your immune cells basically start going downhill in terms of being able to fight things that are foreign to the body, such as the viruses or other things. So it's a combination of the immune system and the receptors that Dr. Tahir mentioned.
Thank you, Dr. Kandahari. I think you're referring to my sister's new Chinese disease called Yang No Mo.
I actually have my own follow-up question, and I'm just going to ask because there's nobody else with a question. I think there are a lot of young people, you know, that they have this line of reasoning that, oh, I should try to get the disease so that I can, you know, then I'll be immune to it or something, and I can go about my life as normal. Is there some flaw to that logic that maybe one of the panelists could, you know, talk about?
The problem is that you are, if you try to contaminate yourself, means you're actively trying to get it, which increases the chance of other people to get that disease from you, and then the total number is going to go up. It would be a very selfish answer.
So kind of now emphasize that young people can die from this disease, and they get very, very sick. We had 30-year-old that was on the vent for almost 6 weeks. And we had 40-some-year-olds sent it to IMED on ECMO. So the disease is kind of, yes, younger people just kind of have less problem and they just kind of do better, but doesn't mean that they are immune from problems.
Besides, you don't know if you're not going to get that disease twice. We don't know the answer. We know maybe short term you're not going to get it. You may get it the second time or the third time. So we don't know the answer to that question either.
Absolutely. You know, you're right. There are people who have been reported to get it again. I had a follow-up question in the chat from Shaheen, which was, how can we better build our immune system? What can we do to have a strong immune system?
Exercise, exercise, exercise.
And balanced diet. Balanced diet is important too.
Okay, I have a question in the chat from Ruzbe, who has his hand raised.
Yeah, thank you very much, everybody and panelists for the time. I just had a question, basically to follow up on the last thing that Dr. Rahimi mentioned, which is, at this time with the pandemic, we really don't know if, the younger people or in general anybody is capable of reaching the virus. And basically, we don't know if it is a one-time deal or if people are going to get it in the future. So even with the vaccine, if it is founded and invented, is this something that, the people around the globe has to take it every year, or is this a one-time deal? For you guys who are involved, I think knows the answer much better. Thank you.
Well, the guy that was studying, I don't remember his name, was in charge of Oxford University research on the vaccine they were working. He's thinking that vaccine would probably be every year or every couple of years. He did not think we can come up with a vaccine that would be forever. I've been thinking about how we can get rid of this disease. It's just that, unfortunately, to me, it looks like in order for everybody to have, for us to have pandemic, like, the one in Mecca in Saudi Arabia, basically the vector was the pilgrimage there, and that caused the spread, and then it stopped. The one in the pandemic flu in 1918 was spread by the war, and it stopped only when the war was over and everybody died that they were supposed to die, and then it stopped. But now that scenario is not there anymore because we travel. We are here today, the next day you're in China. And I think this started somewhere in China. Where it came from, nobody knows. And unfortunately, the bad luck was that the Chinese New Year's was there, and that spread it all over the world. And that's because China has contract with like 240 countries, and people go there for vacation, and then when they go back to the same countries that they had deals with. So that was a perfect scenario for it to spread. And then why do we have it a lot is probably because we travel a lot too in this country. And I'm always, of course, we don't know how many people are going to die in India or those countries but again, one thing those countries have, they might have these villages and stuff that they never traveled, so they never were exposed to that virus, which is very rare because it's very hard to get rid of this. I don't know what the solution is, but the only thing I know is we have to have at least one-time vaccine and treatment for the entire world, and then we have to clear it, and then maybe we have to avoid the big events like Olympics or something that there is big gathering, and then countries like China, when they have the New Year's Eve, then we have to put those precautionary checkpoints to prevent it from having another pandemic. But I think we are going to have more and more, especially we are populating more areas. We are exposed to different animals, because they were saying there are kind of 400 coronavirus in bats alone. So we are exposed to, you can, as far as we invading more territories of these animals and we're living with them, it's a symbiosis. We're going to have more and more pandemic, but maybe we learn from this pandemic, and at least once we have the vaccine, we put the checkpoints, so like for the big traveling between different countries, we put some restrictions and some testing, so we won't spread it as fast.
Thank you. Do any of the other panelists have anything they want to add? I think this might be the last question that we can take before we wrap up. No. Okay. Well, I want to say thank you so much to all of our panelists for the time that they put into prepare for this panel, but also just to be here for this panel and answer the public's questions. I'm really happy about, we got 30 people here, and then we've recorded the session as well, and we're gonna make sure to post this panel on our Facebook page. And so more people can see it who were not able to attend this evening. I think that it's really important to be informed about this pandemic, and I think that we've all learned a lot today. I know I learned some things that I did not know. And please, if you don't follow us already, please follow us on Facebook, Iranian American Society of Utah. And thanks everyone who had questions, and even those who didn't. Thank you for being here. We really appreciate your participation. I'll pass things over to Masoud Abbasi. He's our host here. He can tell us how we want to proceed and close the session.
I want to thank you, Shuan, and your Iranians organization for this, and Masoud and all the people involved.
No, I don't have anything to add. I think you covered it really, really well, Shuan. You did a fantastic job moderating this panel. I think the panelists were wonderful, and we appreciate everyone for participating. Thank you so much.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Thank you, everyone. Now we can leave.